Hello, I'm Dr. David Hornbrook, the clinical director here at Keating Dental Arts in Irvine, California. Today I'm going to talk about what I call one of my practice enhancers. Not only I think is it going to allow me to give more comfortable dentistry, but it also allows me to use technology that I think the patients will talk about when they discuss their dentist in my community. Today we're going to talk about the wand. This came out over a decade ago. It was originally called the Wand, then the Wand 2, then the Compudent, then the STA, and then they renamed it last year the Wand because the familiarity with that name. STA stands for Single Tooth Anesthesia. So let's look at this. This is Jake. Jake, do you mind if I don't wear a mask just for video purposes? Normally I'd put a mask on. I promise I don't have any onions for lunch. All right. So we're going to do a single central on Jake, and the first injection I'm going to show you is what we call an AMSA, anterior, medial, superior alveolar. We all know that if we were to do 6, 8, or 10 veneers, or even a single central, we numb the patient up in the buccal vestibule, and then we try it in, we ask the patient to smile, and of course the lip is like this. Or if we try 6 or 8 or 10 veneers in there, they can't move their lips. So I don't want lip anesthetic, I want lip mobility. Also, with multiple units, let's say I was going to do 8 or 10 veneers, that's 8 to 10 different injection sites. And if you've ever had any anterior dentistry, or you ask your patients or call them the next night, they'll say what was the most uncomfortable was the injection sites. So this is the STA. It has a very small handpiece. I like to use a 30 gauge short, although it is available in different sizes. This would be a 27 gauge long, which if we were to do an IA, an inferior alveolar block, we would use this, although in a moment I'll show you that what we're doing most of the time, 99% of the time, we're giving PDL injections, not the blocks. So we're going to go ahead and use Septicane. The way this machine works, it actually is a computer activated anesthetic delivery device, and it works on back pressure. We've all given paddle injections where you put the needle in, you squeeze, and it seems like nothing's coming out. All of a sudden, a burst of anesthetic comes out, the patient screams because of the pain and the expansion of the tissue, then you back up again. I mean, we have a difficulty giving injections, especially in the palatal. This anesthetic delivery device can give injections much slower than anyone can do manually. And it measures the back pressure and then delivers the anesthetic to compensate for that back pressure. So we can either aspirate or not aspirate. The nice thing about aspiration is once I take my foot off the foot pedal, because it is foot pedal activated, as I pull the needle out of the tissue, the aspiration will actually pull that excess anesthesia that lies in the needle and the delivery wand. It'll pull that back and suction it back so it doesn't go in the patient's mouth. So we're going to go ahead and put the aspirate. We can either leave the STA or not on. That's a single tooth anesthetic. What that does, it measures back pressure to see if you truly are in the PDL space. Lots of times you try to give a PDL, you're pushing, 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 nothing comes out. Other times you push and it just easily comes out of the syringe. You're probably not in the PDL space. So Jake has topical anesthetic in his palate. This is where the AMSA injection is. Go ahead and lift your head high. I like to use these Optogates from Ivoclar. It's a non-latex dam and cheek retractor. The best way to put these on is you just wet it, spread it. You can see it has a stiff outer ring, a stiff inner ring. You go ahead and separate the two. You squeeze in the center. Open for me, Jake. You put one side in, put the other side, put the inner ring behind the lower lip in front of the teeth, and then the upper, and there's our retraction. You can see we have great retraction. We can utilize this to take impressions because we have our vestibule. We also, if we were going to do equilibration, especially with horseshoe articulating paper, tap up and down, you can see he's able to open and close. All right. Is that pinching at all?
No.
Okay. So chin up for me as much as you can and open as wide as you can. Ideally, what we're going to do, and we're going to anesthetize for the single central, but even if it was premolar to premolar, let's say for 10 veneers, we pick a site, imagine the mid-palatal suture, imagine that line, imagine a line right on the gingival margin of the premolars, and then you split the premolars. So it's halfway between the gingival margin of the premolars and the mid-palatal suture and splitting the premolars. So basically right there. Now, do you feel that at all? Okay, so the topical has worked. The way we give this anesthetic is we place the bevel of the needle just against the tissue. Don't penetrate through the tissue. Against the tissue until we get a little bit of blanching. Then we go ahead and put our foot on the foot pedal. You'll hear a beep. After 4 beeps, the machine actually comes on and says cruise, which means you can take your foot off the foot pedal. And then we put this bevel, after the blanching, we put the bevel just slightly underneath the tissue. Wait about 3 or 4 beeps, slightly another millimeter or so, 3 or 4 beeps, another millimeter. What we're doing is chasing the anesthetic. So you'll probably feel a little pinch and certainly some pressure. Jake, you may feel a little pinch and certainly some pressure, okay? And it's probably going to taste really bad. Open for me, so I'm going to go ahead and take the bevel and needle, putting against the tissue on the foot pedal. You can see the tissue start to blanch. There, the STA just said cruise. I'm going to go ahead and put it in the tissue a little bit. 2, 3, 4, about 4 beeps, a little bit further. Okay. That's the aspiration, so it's actually pulling it back into the syringe, the handpiece. All right. So he already has a little bit of anesthetic superficially, in about the millimeter or 2 millimeters in the tissue. So you shouldn't feel this at all. Do you feel that?
Mm-mm.
Okay. Okay. 4 beeps, another millimeter in. 4 beeps, another millimeter. Do you feel that at all?
Mm-mm.
Now we're going to go ahead all the way to periosteum. How you doing, okay?
Mm-hmm.
Okay. I'm going to give him about a half a carpule. Again, there's the aspirate. Let me give him a little bit of water. This is 4% septicane, articane hydrochloride. Again, tastes terrible. All right, I'm going to do the other side. Turn toward me. Now I'm going to give an example as if I was, let's say, seating 8 or 10 veneers. I'd want both sides to be anesthetized. He'll have anesthetic, full tooth anesthetic, and the palate from the first molar to the first molar. And about 10% of the time I get some buccal anesthetic, but no lip anesthetic. So same thing, right against the tissue. 1, 2, 3, 4. Go about a millimeter in. 2, 3, 4. Another millimeter. 1, 2, 3, 4. And then I'll continue that until I have about a half carpule, a quarter of a carpule, or a half carpule per side. And I'll have full anesthetic. Typically I can seat 8 to 10 veneers, 2.5 hours, with only 1 carpule or less. And the nice thing about this is he will have only 2 injection sites in his palate. The amount of anesthetic is obviously reduced significantly. And as we check the smile, check the shade, check the shape, he will have full ability to smile. Okay, let me give you a little bit more water. And now I'm going to show you how we do the PDL injection. Close and swish a little bit if you can. Now, as I mentioned earlier, rarely do I give infraalveolar blocks, even for lower molars. And I do a lot of dentistry, so it's not that I'm just doing anterior or forward. So on the first molar, open real big. Again, I like to use the 30 gauge short. I bend it a little bit, turn toward me. I'm going to do the first molar, the mandibular right first molar. You can put a little bit of topical or not. Usually I don't feel this. You're going to feel a little pinch though. I put it down into the space, firmly, put my foot on the foot pedal. Watching the STA device to make sure I truly am in the PDL space. I'll usually give about 10 beeps, pushing firmly into the space. And then that's the aspiration. Okay, let me give you a little bit of water. Close and swish. Did you feel that much?
Mm-mm.
Now typically what I'll do is I'll give it in 4 locations. Open real big. For molars, I'll go at the distal lingual line angle, the mesial lingual line angle. Sometimes that'll do it, but I like to ensure that my patient's numb. I will go the distal facial line angle and the mesial facial line angle, just into the PDL space. Again, you're pushing hard, basically until you hit bone and you're in that space. And typically I'll give about 1/4 of a carpio, maybe a half carpio for a hot tooth. That's the total anesthetic I'll give for that single tooth. The advantage of that is he will be able to operate his tongue, his lip will not have anesthetic, he'll be able to function normally. All right, so again, those are just 2 injections. We can give mentals. My hygienist actually use it, especially when does scaling and root planing, because again, less anesthetic, more comfort. It's not the syringe that's coming at the patient that certainly elicits anxiety with many of our patients. And the benefits as I look at this instrument, one is less pain and anxiety, which is huge for me. Second is less anesthetic, which I think we should always try to avoid using excess anesthetic. Third is that the patient is much more comfortable after the procedure. You know, I always say that if I did a DO filling on Jake, after I polish and just occlusion, he leaves, I'm done with Jake. He's not done with me. He's still numb for the next 45 minutes to an hour, especially if I give an inferior alveolar. With this type of injection, he's basically numb. Very limited residual effect of the anesthetic. And fourth, as I mentioned earlier, just the marketability. When he goes back to his office and he said he just went to the dentist and they say, oh, how come your lip's not dripping? Well, the nice thing about that is the type of anesthetic and the type of injection using the STA. So I hope that helped in certainly educating you a little bit about, again, one of the quote-unquote I call my practice enhancers, something I use in my practice every day and I can't imagine working without it. Visit us for other videos and some of the very cool education we're doing here at Keating Dental Arts at www.keatingdentalarts.com.